Welcome everyone to the show. My name is Tim Hayden and I'll be your host. We have a fabulous episode today. Our guest is Dr. William Obremskey. Dr. Obremskey is an orthopedic trauma surgeon and he is a specialist at Vanderbilt Medical in Nashville, Tennessee. He's been at Vanderbilt since 2002. He received his undergraduate and medical degree from Duke University and has been in practice since 1994. He has published numerous articles, and on top of all of that, he is also a necrotizing fasciitis. Please welcome Dr. Obremskey. Hello, Doctor.
Hello, Tim. Thank you for the opportunity to be here.
Thank you for being here. Um, why don't you tell us a little bit about yourself to get started?
Sure. I'm an orthopedic surgeon at Vanderbilt, and I've been here 20 years. I grew up in a small town in Indiana, Lebanon, Indiana, and then was, as you said, my undergraduate medical degree at Duke. I got a master's in health policy at UNC. I trained in Seattle, Washington as a orthopedic resident, and then was in the Air Force for 3 years in Tucson, Arizona. And I did a trauma fellowship after that in Switzerland, and was at the University of North Carolina in Raleigh at the trauma center there for 5 years before I moved to Vanderbilt in 2002. I've had an interest in orthopedic trauma and clinical outcome research, and I think part of what we do at Vanderbilt is try to make things better for patients. I think we all know we can always make things better, and so that's been a big focus on clinical outcome research for me in orthopedic trauma specifically.
Well, Vanderbilt's one of the leading university hospitals in America, so, I mean, that says a lot on its own. Did you always want to be a doctor?
You know, for the vast majority of the time, I thought I would be a vet when I was really young, and toyed with the military. But I decided I liked medicine and wanted to, I think, help people and make a difference. And I thought medicine was the best way to use the talents I had.
And it is. It takes a lot of work and education and practice to do what you do. I certainly could not do that. I'll get right into it. What is some of your experience dealing with NF other than your own situation? I'll get to that a little bit later.
Well, you alluded to that. Maybe I ought to give a little background about that as well, just for full disclosure. It's pretty unusual. I live in the work in the mid South, and if you heat map the country, Tennessee, Kentucky, Alabama have all been areas with hot spots in terms of necrotizing fasciitis. Something about that region. That's where much of the literature came from, even in the Civil War, and that the surgeons that really described it were found in part of the Confederacy, and talked about necrotizing fasciitis there. It certainly isn't new. Socrates described it 2,000 years ago quite eloquently, and we can maybe talk about that. But it's an area where we have seen a fair amount of necrotizing fasciitis, and I've seen up to 5 patients in a week, and 3 in a day at one point, a while ago. But so we see it here, and so in let's see, maybe 2008, I got a call from a friend of mine who a patient had come in and had some bricks land on his thigh, and he had swelling and pain, and he walked into the ER the night before at 6 in the morning. They had him in the operating room, and his leg was dead, and they needed to cut it off. And the general surgeons wanted help with it because it was very proximal up into his groin. And so he called me, my friend called me, and I went and I helped him take the guy's leg off. He did better for a while, and then unfortunately about a week later he died. And just from overwhelming sepsis and just not being able to recover. And so a little after that, 8 or 9 days after the initial incident, I really wasn't feeling very well. I thought I had the flu. Had actually been out on my daughter's birthday on a boat, and came home and exercised, and then just told my wife I was going to bed early. Then the next day, I was kind of tired in the OR. They actually have pictures of me in the surgeon's lounge where I am just passed out sleeping, and I'm usually pretty high energy, and what's going on. And they literally couldn't get me to the OR. I was probably beginning to get sick. So then the next day I was really not well, and eventually got admitted to the hospital and wanted to go home, and I had a little redness in my right leg, and I'd had a total hip on that side, and I wasn't sure what was going on. I was worried about that. And then I was sort of intubated and out for about 8 days, intubated in the ICU with had progressive necrotizing fasciitis in my right leg. What probably happened was that I became colonized with the patient who had group A strep, and then it sort of just was part of my oral pharynx, and either hand to toes, cough in my hand, pick up my nose, who knows what, put it into a chronic athlete's foot. Clearly started in my web space, third and fourth web space in my toes, and then just sort of took off from there. And luckily I work and live at Vanderbilt, and one of my good friends, Addison May, was the president of the Surgical Infection Society, and I had called him, and he came to see me in the OR in the hospital, and immediately wheeled me to the ICU. And I eventually got cut from my toes to my groin, but I didn't lose a leg. And I had toxic shock syndrome, which is sort of the systemic effect of particularly group A strep, and was pretty sick. But luckily, with some good advice and good physicians taking care of me, I survived. And I've got some great scars and a good story. And I'm here to sort of with all limbs and to talk and tell about it. So it's personal to me, and hence why I responded when you found me and asked me to talk about it, because I think it's an important thing. It's one of the few things that orthopedic surgeons in general can do to save lives. We can stop the bleeding, and we fix fractures and make quality of life. And in general, we're about quality of life and function, and less about saving lives. But this is not that common, and in the community, surgeons are going to see it at some point, maybe just a couple cases in their career. But I think it's important for them to understand and to recognize what they're seeing, and that the biggest cause of mortality is delayed diagnosis of mortality. Sometimes you can't save, it's too far gone before you get there in terms of the limb. But there's no doubt that mortality and amputations are related to time to surgery from initial presentation. So I've been active in, sort of writing about it, trying to understand it. I've been a resource, and we've written a number of articles on it, trying to just help people understand some of their options, and that the urgent need, because you're going to see it. At some point, you are likely to see it if you're a surgeon on call in a major trauma center or a community hospital. And it's interesting. It's not just, some places it's plastic surgeons, sometimes it's general surgeons, some places it's orthopedic surgeons that get called to take care of it. But luckily, the surgeons in my hospital recognized it and took care of me, and I'm here to talk about it more.
Do you have any lingering after effects from your NF?
I have a little bit of leg swelling. I wore compression socks on my legs for 5 years. Just from the chronic edema. And so that still is, I often tell patients that they ask me how long swelling is going to last. I say, maybe 5 years or forever. And I said, I got better scars than you, and I had, swelling for a long time. So I have that effect. Physically, I'm fine. Interestingly, when I was out, I apparently was a fairly active patient, and I was pulling on my restraints, and so they eventually tied me down. I don't know if you can see, I have it's called an eschar. I said I had a pressure sore on my wrist from where I was tied down really tight, and my median nerve didn't work when I woke up. And because as a median nerve, I couldn't, is an important nerve to function of your hand, that I couldn't operate for 6 months, which was somewhat maybe a blessing in disguise. Gave me time to recover physically and psychologically, emotionally, to where I could go back at it again. I think it would have been really hard if I'd have been at 2 months. Okay, physically you're here, go to work. And that occasionally tingles, when the weather gets cold. That's about the only physical complaint I have, and a little bit of swelling.
You brought up a good question I was going to ask you about later on, but I'll go ahead and do it. What do you feel like when an NF patient is being discharged, you have to go through a checklist, occupational therapy, physical therapy. Would you recommend psychological therapy as well? Because I know running our nonprofit or our group, a lot of people suffer from PTSD from their experience.
Yeah, absolutely. And we have actually before this event, I had done a fair amount of research on the psychological effects of multi-trauma patients. Just that we know that we may get their bodies back, but a third of patients have PTSD, depression, anxiety. And every single patient that I see in clinic, I have sort of a checklist of things that we give them. Like, what do you need? Do you need a handicap sticker? Do you need a note for work? Do you need medication refills? How are you sleeping? Do you have signs or symptoms of PTSD, depression, anxiety? I'm not licensed to treat those things, but I can certainly begin the process of acknowledging it to the patient that it's real. The young males are the worst. They just ignore it, but their families know, and encourage them to seek care from either in our system, we can refer them in our system, or in their local system, usually starting with their primary care provider, who may or may not be comfortable, but could certainly be a resource to address. And I make them promise. I make the spouse promise that they will, help the patient seek care, because you got to get their body and their brain back into working function if they're going to really re-enter society effectively.
And I like what you just said about getting the family involved, because basically they went through the same trauma. They just didn't have the physical part of it. They had to make the decisions and live through all of that as well. I've got a couple of questions from some people who submitted. Let me get to it here. Sorry. Even after a wound is closed, how long does it take for eternal trauma to heal? They took a 3-inch deep section of flesh out of that spot, has a deep pain, and you can feel a hole beneath the scar.
Yeah, I'm not sure I can answer that. I mean, a deep hole sounds like they had a wedge of tissue removed from their infection. And that is probably highly dependent upon, where it is, how long it is, and the mechanism utilized. For years, all we could do is pack wounds, and that's a months or weeks or certainly months long process for large wounds. And the invention of the wound vac, within the last 15 to 20 years has, I think, changed that, and the wounds heal in faster. Some people don't like. I mean, just Wednesday in clinic, I asked a patient, well, we can wound vac this, and it may be another couple of weeks, or we could just do wet to dry dressings, and it may be a month or two. And I said, some people don't like the wound vacs of, the suction device, and it sticks to their skin, and they hate changed them. And so I give them an option, and I think the wound vacs help it happen faster. I've had my own wound vacs. I wound vacs on my foot and my groin and PICC line, and so I can relate to patients on some of these issues. I said, I changed my own wound vac also. You can do it.
Well, speaking of that, I consider you what I would say a unicorn, because you are not only a surgeon, but you actually experience this. So you see it from both sides, whereas most doctors don't get that opportunity. I hope they don't, because it's a traumatic experience. I went there myself.
Yeah, you're right. It is highly unusual, and I sent you some of the things we have written in the past,
Yes.
And one of them is that this case report of sort of patient to physician transmission is the one and only reported in the literature where the provider had toxic shock syndrome after me. And I would say that's not the way to pad your CV and to get famous. It's a little risky, but it is truly unusual. There certainly have been healthcare worker transmission. And I think one of the points when I give talks on this to people is that in the healthcare setting, that if someone is, toxic sick and with an infection, and you don't know what that bacteria is, and they haven't been treated for 48 hours, you should probably wear an N95. I mean, 5 years ago, people were like, what's an N95? Never heard of that. But now the world knows what an N95 is. And if you're a healthcare provider with a sick patient with what's thought to be potentially necrotizing fasciitis, you should probably wear an N95. Our hospital has changed their recommendations to policy to reflect that because of the significant risk of transmission, oropharyngeal transmission, and then from there to other people. And as a healthcare provider, you don't want to bring that home to your family or to yourself. And so make a strong recommendation. That's one of the things that we can do to try to help ourselves and those around us to protect ourselves. We're going to have to take care of these patients. I mean, they come in, we have to take care of them. People ask me, how do you do that? I mean, I signed up for this. I shouldn't shy away from that. I mean, I'm on call. It's my job. I'm going to take care of it if you have necrotizing fasciitis, and maybe I'll recognize it sooner since I've seen a lot of it and I know what it can do to people. Right. So I think those are some recommendations I have for people, are to recognize it and to protect yourself in the interim.
I know when I went through it back in 2006, there wasn't a whole lot of information, definitive information out there. And after my surgeries, they put me in an isolation type of thing where if anybody came in, they had to wear a full gown, everything, just as a precaution to protect me from outside, but also to protect them from possibly getting it like you did. Is it normal to have severe fatigue long after physical wounds heal, like 2 years after your wounds closed?
Potentially. I think the long-term psychologic effects and physiologic effects of severe illness are not completely understood. Hence, long COVID. I think there are some people who get it and bounce back, and there are some people who get it and have residual, chronic fatigue and or illness or weakness, and are more susceptible to infections in the future. I don't think I'm sure we don't completely understand why. I mean, I'm sure there's a physiologic and a psychologic component to that, but I think it's real.
Was that something that they'll always have to battle, or is there something they could do, like you said, it might be psychological, maybe see a therapist that might help them?
I would definitely see a therapist. There's no doubt that, depression, anxiety, all contribute to those symptoms. And I know for sure that I don't know the definite answer to that. I think there, may be physiologic things we don't understand, that they're just there. It depends on how sick they were. Is their pulmonary capacity just bad, worse because their lungs were severely damaged? And, we know long periods of immobilization leads to muscle mass loss that could all contribute to the physical symptoms as well as the psychological symptoms. I would say talk to their healthcare provider and consider a referral to a mental health provider and as well as therapists for physical therapy to work on the physical and the psychological aspects. I don't know how long this person has been since their injury, or since their illness, but it can be a long time.
Well, this was right up your alley, I believe. This is from Germany, survivor. What do you think about Z plastic on the tendon at the hollow of the knee in order to get the same range of motion as the left leg? Is it too much risk hurting the tendon, or worth a try to avoid consequence caused by imbalance due to different ranges of motion?
I would assume that they maybe had infection and some skin loss in the back of their knee, and that they now have a knee flexion contracture, which means the knee doesn't straighten all the way. And if the knee is crooked and doesn't straighten all the way, it's very hard to walk. It's a real problem in any injury that I take care of. And so if the primary problem is in the skin, then a Z-plasty is a very effective way to release the tension and to lengthen the skin so it's not so tight. And our plastic surgeons usually do that. And if that's the primary complaint, I think it's certainly it's a relatively low risk with potential huge benefit of walking better forever.
Is there a risk of worsening lymphedema, which is on another site about 25 centimeters away?
Is this the same?
Yes.
Sure. As I tell almost all my patients, there's nothing you can't make worse with an operation, so things can always get worse. You could get necrotizing fasciitis from your incision. So always possible to get worse. It's just because everything is a risk-benefit ratio. And if this condition is a significant effect on the quality of life and physical function, then I think that that person should have a conversation with their physician or a different physician if they don't trust that physician, to try to make a combined, joint decision-making process to try to come to a good decision on what's right for that patient at this time.
Well, I know who we're talking about, and she's very active. She likes to walk, run, do all riding bikes, things like that. She's a very active young lady. So do you actually have an idea of what the percentage of NF mortality is at this point?
It's somewhere between 10 and 70% as things that have been described. And so it depends on time presentations, many of where it is in the body. It's much more fatal on the corpus, on your body, and your groin. Fournier's disease has a much higher mortality than one that starts in your foot. And the age of the patient and the timing of diagnosis. So it's somewhere in that range. Vanderbilt published the 10% mortality when the average had been around 20. And we attributed that primarily to early operative debridement.
And awareness.
Sorry. To get to the OR, you have to be aware.
Because that's our main objective, is spread awareness to do what.
And good for you. It's not that common. And many surgeons will see one case in their career, and it has multiple facets of how it presents. And so raising awareness is excellent and may save some lives. And so, kudos to you for making this an effort to try to improve knowledge. There's nothing wrong with learning more and improving knowledge.
Yeah. I'm not, this isn't a question because I'm not going to put you on the spot, but I've talked to a few medical students who've recently gone through medical school, and I asked them how much they went through as far as learning about necrotizing fasciitis. Most of them said it's about a paragraph. They spent about 15 minutes on it.
That's probably right. Having two children who just finished medical school recently, that's probably true.
Not, like I said, again, not a question. I'd like to see a little more taught about it, because it's rare, but it's a little more common than it used to be when they considered it being very rare.
Yeah, medical school may not be the place that's in the training programs. If you're in a specialty that is likely to see somebody with that, to have it's great for general knowledge, but also for those who will see the sickest people, ER docs, surgeons of any kind, I think and then even family practice, primary care people who may recognize, get that sense that something's not right. This is different. You need to go to a higher level of care.
And somebody said, that's a very nice Gibson clock behind
you. I live in Nashville, Tennessee, home of Gibson guitars.
Absolutely. Well, Dr. Obremskey, thank you for being here today and talking with us. I don't want to take up too much of your time. I know you're busy. If you don't mind, could you hang out backstage just for a couple minutes? Let me close this out. I want to talk to you about one other thing.
Sure, happy to. Again, thank you for the opportunity to talk and to do that exit.
Well, I appreciate it. I know my viewers do as well. I'll be right back with you in just a couple minutes.
Okay, thank you.
I would like to thank Dr. Obremskey for being here today. Thank you for tuning in. Please subscribe to our YouTube channel for more great shows. Please remember to be kind and to smile